The average annual premium for employer-sponsored health insurance for a family is now more than $23,000 per year and climbing. That's just crazy. It's also unsustainable. Many companies have given up hope that anything can be done in healthcare to lower costs and improve value, leaving them feeling like a snowball in, well, you know where. I'm Josh Butler, healthcare consultant and advisor to employer organizations around the country, and this is Season 2 of A Snowball's Chance in Healthcare, a show about restoring hope in healthcare. Our mission is to help employers lower their healthcare and benefits costs, become more competitive and profitable organizations, and put more value back into their employee benefits.
And now, here's your host and 2022 Broker of the Year, Josh Butler.
Hello again, and welcome everyone to another episode of A Snowball's Chance in Healthcare. It's a great day in the Texas Panhandle. Welcome back to another episode. My name is Josh Butler. I am the president of Butler Benefits and Consulting. We're a boutique healthcare consulting and brokerage firm located in Amarillo, Texas. I'm also the program of this show, A Snowball's Chance in Healthcare. And each week we're sharing tips and strategies and hosting amazing guests to give you and your employees a snowball's chance in healthcare. And we're going to jump right in today. I have been waiting quite some time to land this guest on my program. She is one of the most intriguing, intelligent, funny, smartest people bravest people I've ever met. She is a role model to so many in our industry and an inspiration, including myself. Marilyn Bartlett is with me today, and I'm going to do a real quick intro before I let Marilyn jump in, so everybody in the audience and everybody out there listening can understand just who we're visiting with today. Marilyn Bartlett works today for an organization called NASHP. She joined NASHP in November of 2019, and NASHP, N-A-S-H-P, stands for the National Academy for State Health Policy, and it's a nonpartisan organization that's committed to developing and advancing state health policy innovations and solutions. Now, Marilyn's going to talk a whole lot more. We're going to talk more about what she does specifically at NASHP. But even prior to that, before she went to work for NASHP, Marilyn held various financial management positions, including serving as a controller for Blue Cross Blue Shield. And probably most notably, she managed the Montana State Employee Health Plan for several years and was a special projects coordinator for the Montana Commissioner of Securities and Insurance. Now, like I said, a lot of you folks know Marilyn and are familiar with all of the success that she's had in our industry and that she's had in her career. But those of you who may not know, when Marilyn ran the state of Montana's employee benefits plan, she inherited a plan that had, what was it, Marilyn, a reserve deficit of about, wasn't it around $9 million?
Yeah, it was headed to minus $9 million in less than 2 years.
And exactly. And when she left about 3 years later, Maryland had helped the state turn their health plan around and reverse that $9 million reserve deficit to $112 million surplus in just 3 years. Correct, Marilyn?
Correct.
That is amazing work. Well, and for those accomplishments, ladies and gentlemen, it earned Marilyn. She was named number 13 on Fortune magazine's World's 50 Greatest Leaders in 2019. Now, listen, I said the world's 50 greatest leaders. So she's an amazing inspiration. And I'll tell you, you better look out, folks, because she says what she means and she means what she says. And she's packing a Medicare card and she's not afraid to tell it like it is. So, Marilyn, it's such an honor to have you on A Snowball's Chance in Healthcare. How have you been, my friend?
Well, first, I want to thank you. Thank you for inviting me to be part of this podcast and doing well, still living here in Montana, but working on several things.
Yes, absolutely. And I know that you are a very busy person and you've taken on some newer responsibilities over at NASHP. And so we'll jump right in. I mean, if you don't mind, I'd like to give our audience as much time with you today as possible. And tell us a little bit more about NASHP and more specifically about the work that you do there that's helping shape and support state health policy.
Certainly, NASHP's focus is helping states with health policy. And when I came to NASHP, I had a little Excel tool that I had built when I was negotiating with the hospitals in Montana. Because if a hospital came back and told me, we can't lower our rates, we're losing 40% on Medicaid. Well, I needed to know if that was true. And what I would find is I needed to know the payer mix also. If you were truly losing 40% on Medicaid, but it's only 9% of your payer mix, that's a real different story than if it's 30% of your payer mix. I needed to know the hospital's status. I needed to know their profit margins. I needed to know their cost per adjusted discharge. You can tell I'm an accountant. And I calculated the break-even point. At what point, based on Medicare rates, at what multiple of Medicare did I need to reimburse that hospital for it to break even? And then I ran my claims through a Medicare repricer, so I knew what that spread was and what I could negotiate with the hospitals. Well, NASHP was intrigued by that, and the Arnold Foundation funded the work. And I further developed this Excel cost tool to be able to calculate a lot of metrics on a hospital. And we worked with Rice University in your state, Dr. Vivian Ho and team. They helped us kind of link that tool to the HCRIS database that contains all the fields of Medicare cost reports back to 2011. So we were able to get it all automated, and you can track trends, you can compare states, you can compare hospitals, and then we worked with Mathematica to get it to be an online tool. So that was my work at NASHP, and what we found was my focus was developing it for employers. So they, like your group does, like you do a lot, Josh, of direct contracting with hospitals, and it's a good thing to have to know the hospital's financials before you sit with them.
Of course.
So that was the focus, but then we found that it was very helpful to state policy. We found some states that were really interested in knowing the hospital's financials, interested in knowing what happened pre and post mergers, pre and post COPA agreements. They wanted to know that trend. Now, this year we updated the tool to include some direct patient care statistics. What happened with direct patient care during COVID, and where does it stand now? And what happened to hourly rates? Maybe contracted direct patient care was 105 an hour, where your direct patient care was 65 an hour. But what percent was that? If it's only 1 or 2%, maybe it's a different story. So now I'm into the nitty-gritty numbers and boring our whole audience, but that's what I've been doing at NASHP.
No, it's completely not boring, and I think it's absolutely more than intriguing. It's necessary, but I want to go to some more examples of the type of data. So for our audience, you mentioned some things like their costs and their cost to charge ratios. I know that's something that I pay really close attention to. You just very well described the commercial break-even point of where a commercial plan like a Blue Cross Blue Shield or Cigna or Aetna or Humana, at what multiple of Medicare would they need to pay the hospital in order for the hospital to turn a profit, right? And so for all you guys out there that are listening, I mean, this isn't just applicable data and information to public sector plans or to states. I mean, this is information, to Marilyn's point, that we use at Butler Benefits in order to help us get direct contracts with clinicians. But I want to get to a question that comes up all the time, Marilyn, and it's this: it is the validity and the integrity of the information. Tell us where this data actually originates. I know you said it a second ago, but explain that a little bit again.
Very good question. The data originates from Medicare cost reports that are submitted by every hospital that does take Medicare reimbursements. Right now the tool has 4,600 hospitals in it.
Right.
So it includes not critical access hospitals, and then the acute care hospitals. We didn't include some of the psych and specialty hospitals. And the data is all hospitals submitted. It's attested to by the hospital CEO, CFO. They have to sign that it's correct. And it's the only public source of hospital cost information. We're starting to see prices be transparent, but this is the actual hospital costs.
Right.
So we worked with Rice to make sure that our calculations and our sources were all valid, with some help from RAND also, as you know,
Yeah.
the RAND tool that they use. So yeah, it all comes from hospital submitted data.
Yeah, so it's a fair assessment. It's a fair statement to say, and it would be an accurate statement to say that if the initial data is wrong, it's because the hospitals provided wrong information initially.
Mm-hmm. That's correct.
Okay, so I mean
Yeah.
that is a critical point that is how you maintain credibility, in my opinion, is that you're not deriving this data. I mean, you're getting the data, but it's not data that you went and submitted to CMS on behalf of the hospital. It's the hospital's own self-reported data, correct?
Yeah, it is. And when we first developed this, we connected with there were three very large health systems, hospital systems. And we asked them to look at our formulas. We asked them to look at the data. We asked them to push back what might be right. And there were a few things we changed. It was good feedback. So we did get input on the calculations. And like you just said, it is public data and it is submitted and attested to by the hospitals.
Now, with this hospital cost tool, you guys are aggregating this data in a very user-friendly type of way. Is this tool available to the public?
Oh, it certainly is. It's available online. There is a link on the NASHP website to it. And you're going to ask me what that link is, and I'm just sort of blank.
It's a long link. We'll put it in the comments when we post it. When we post it on the, we'll be sure to add it to the show notes, and we'll put it in a link to the hospital cost tool, because I can tell you, it's a tool that I use, like I mentioned, and I'll give a real quick story. You mentioned that we use it to start conversations and negotiations with hospitals in order to get direct contracts. And not too long ago, we had started a conversation. They were very intrigued with the concept of direct to employer contracting. And they came in and they said, well, this is what we need to make. We're losing our shirts if we get anything under X. And because of this cost tool and because of the reports that you can download in conjunction with the cost tool, we were able to have a conversation with them on a level they weren't expecting. And you know what they did, Marilyn? They went back and said, well, we're going to go back and we're going to take a closer look at our managed care contracts. And 2 weeks later, the CFO came back and was like, hey, you're right, actually, and your numbers are sharper than our numbers. And so we're going to do a contract with you. And so there's a testament for the work you've done. But you mentioned you started this type of Excel spreadsheet more than likely back in Montana. Is that right?
That's right. And thank you for sharing that story. That makes it all worth it. That is wonderful. And you're out ahead of the group in really working with your employers to really bring good solutions to them. But yeah, I used it when I negotiated with all the hospitals in Montana, because we changed the reimbursement from a discount off charge to Medicare, a multiple of Medicare. I'm an accountant and I like cost plus better than I like an arbitrary charge master rate with a secret negotiated discount. I don't want that. And we do offer in the hospital cost tool, one of the charts I like the best is I show what's happened to hospital operating costs over time. And it doesn't go up that much. But then you see the charges and the charges just climb. So it's a good chart to say, do I want to discount off this or do I want a multiple of this? That was eye-opening when I did that in Montana.
And that is a great point, because when we show that to employers, that if you're on a contract predicated off of a discount off, and even at a fundamental individual level, as people go in, maybe they're uninsured and they're trying to negotiate a cash price, they're always trying to get a negotiated price off of the charge instead of but they never, an individual they don't have access to this kind of data to say, well, I know what your costs are, and that's where I want to start. Employers don't realize how significant of a difference that alone will make if they're a self-funded employer, right?
Oh, absolutely. And having that information on the hospital costs, definitely, it really will help employers.
Yeah, absolutely. And so that's one of the things that I see as very intriguing. And then another thing that you mentioned, that you this new feature that y'all have added to the hospital cost tool, is how much hospitals are investing in literal and direct to patient care, how much they're spending per patient or per discharge on, specifically on patient care, not on their parking lots or their
Right.
marble floors in their lobbies and their escalators, and and I mean, so tell us a little more about that. Do you feel like that's more of a quality metric as more than a financial metric to see what a hospital is investing directly into patient care versus those who aren't investing so much?
Yeah, I think it's both. That's a really good way to look at that, Josh, because it is looking at the quality of the care, and it is looking at the financial. On the financial side, we have a chart on the online version that shows the net patient revenue for adjusted discharge and the
Right.
hospital costs per adjusted discharge. And that spread is the operating profit before you get those other items in there. And it's interesting to watch. What we see over time is, does that keep spreading? Are they getting more operating profit? Are they following in line? We actually have found more than not on not-for-profit hospitals, we find that incline going up and up and spreading. There's less of an incentive to keep those costs down. And every hospital system manages differently. I'm not saying that's good or bad. And on the for-profit systems, you see a little bit more attention to costs, and they're a little bit flatter. And that may be, you have to look at quality then too. Yeah, I think it is good to bring it down to the per patient level and compare it to different hospitals in your area.
Yeah. Yeah, because if you see those margins, and the margins are getting bigger, but you see that hospitals also investing more financially into direct patient care, that's a good indicator to me that they're
Yeah,
trying to do the best they can for their patients. I mean, that's just kind of been
I think so too.
my West Texas boy interpretation. So, but I want to get over to some different work that you're doing as well. And I'm not going to have time to get into the RAND 4.0. I'd love to have
Sure.
you back in the future where that could be a whole topic in and of itself to talk about what you guys are doing at NASHP, coupled with the RAND studies, and how you coupled those data sets together to really give us a full picture of not just what's the commercial break even point, but what are these hospitals actually getting paid by the insurance companies? And I think that's a question that intrigues a lot of people. And we talk about it a lot on this program about why is health insurance so darn expensive, Marilyn? And we're talking about it right here. Over 58% of all the expenses in healthcare go to hospitals. So it's a very important topic. But the federal government just passed a piece of legislation, here recently in recent history, called the Consolidated Appropriations Act. And I know you're doing a lot of work in these areas as well. I want to talk about two provisions of the Consolidated Appropriations Act, which I've covered multiple times here on the program. And I want to talk about sections 201 and 202, because I know you are intimately involved in understanding, interpreting, and also advising people in these areas on these two provisions. Section 201 says that it prohibits group health plans, health plan insurers, and insurers of health insurance coverage, also known as covered parties. Who's a covered party, Marilyn?
I think what that 201, which I really like, it addresses not only employer self-funded plans, but it does the non-federal government public health plans. So all your schools, state, counties, all of them are under that too, and the health insurance. They're all included, that they cannot have gag clauses in their contracts. Now, as you mentioned, the law does address, it talks about TPAs, but it does say and other service providers. So for me, that opens it up to PBMs. It opens it up to every single service provider. You can't have gag clauses in your contracts. Now, it's administered through CMS definitely for the public plans, DOL for the non-public self-funded plans, and then IRS it's a tri-party regulation. They just came out Thursday, February 23rd, with FAQ and guidance, which was really missing. We did work not through NASHP, but through another group called Patient Rights Advocate. We worked greatly with at the federal level to get guidance and information across. They just came out with that. And I think all employers are going to need to be looking at that, because it also includes an attestation form that has to be completed with deadlines on it. And the thing I like about the attestation is it also includes that those service providers have to attest they're not gag clauses, but it still puts the major onus on the employer to get that done. So it's good. It's really good. And we are using it. We're seeing it come up as a reference in some legal suits. You may have seen the one in Connecticut filed by unions, the one in Massachusetts filed by unions, and a recent one filed by Owens and Minor against a large health carrier in Richmond, Virginia. And it's to get access to their data. Their contracts do contain gag clauses. So it's gonna be interesting to see what the courts do now.
Absolutely. And I think, and it's unfortunate that it's gonna, but I predicted a long time ago that that's how it's ultimately going to be resolved, is through the courts. But, so people understand what Marilyn's saying, these gag clauses in the contracts. So in a lot of states, including a lot of times in Texas, we get certain data, but we're talking about full data. If carriers are not providing claims level data to an employer, that is considered a gag clause in your contract with that insurance carrier. And therefore, it doesn't put the insurance carrier out of, well, it does. It puts the carrier out of compliance, but more importantly, it puts your company out of compliance. And there are penalties that are coming, and there are lawsuits they're on the horizon. And this isn't, it's not a threat. The Consolidated Appropriations Act is in effect. It's law of the land, right, Marilyn?
Yes, it is. It's federal law.
And now let's move to Section 202 of the Consolidated Appropriations Act that we've talked extensively about here, about the full disclosure of all direct and indirect compensation paid to brokers and consultants. Now, that's a practice that we have voluntarily participated in at Butler Benefits for a multiple of years, because we're members of Health Rosetta and we just philosophically believe in transparency. But when you say that 201 is when they mention other service providers are applicable to even PBMs and TPAs, do you feel 202 is also applicable to those service providers?
Absolutely. I think as you read it, it is to service providers, and the employers I have spoken with, I've encouraged them to really push that forward on even some of the ancillary products they have, as far as wellness programs. If there's a disease management program, you need to see the money flow back and forth, your TPA, your PBM, and you need to do it. And it's your responsibility as the employer. You're the one that is to be doing this. Now, that particular provision, as you well know, does lay out some very strong guidance that if you do not hear, or your broker, your service providers does not respond to you, does not provide that, there are certain deadlines and steps that you are to take.
Right. Yeah.
And I have to give you a tout. You and your whole Health Rosetta team were way ahead of this. You've been doing this for years, and now it's trying to get the rest of the market to do that. And I'll tell you, they're very slowly to responding, very, very slowly.
Are you talking about the government or employers or both?
I'd say both.
Or brokers?
They did offer an FAQ on that and Health Rosetta, I think, was really, really helpful in moving that forward. That was just a great advocacy piece on all of your parts. But we've seen some of the large brokerage houses taking maybe a little bit longer. And it needs to be pushed, and employers need to know it's their responsibility to do it.
Yeah, it certainly is. And as we wrap up here, Marilyn, we're getting close to the end of our time together. Unfortunately, we need to do another one and just make it part 1 and part 2, part 3 and part 4. We could talk for hours about this stuff. But last question I wanted to kind of wrap up with, and thank you again for coming on the program. But when I go talk to employers and we have these conversations about disclosing income and disclosing indirect and direct revenue and from your PBMs and your TPAs, they almost take this, some employers take an attitude of Chicken Little, like, oh, the sky's falling, you're making it seem way worse than it is. What would you say to employers, what you see when you dig into this and you're way in the trenches, you're way behind the weeds, right? How bad is it? And should employers be concerned?
I think, first of all, the employer needs to be concerned because they're a fiduciary on the plan, and you need to make sure that basically, well, what the law says is that you are paid reasonable expenses. Those are plan assets. And as a fiduciary, you've got to make sure you know where that money's going to. When we do dig in, we just looked at one for an employer of 1,600 employees, and they were paying their consulting firm $120,000 a year. When we were able to get all the information back from the commissions being paid to the TPA, who had placed the pet insurance, the long-term disability, the life insurance, all the different things for that plan, there was an additional, that brokerage firm was receiving $594,000. So no, and you need to know that as a fiduciary, I like the employers that are stepping up and doing this, and the consultants like you that are bringing that forward, because they need to know that from the fiduciary standpoint.
Absolutely. Well, Marilyn, thank you again. We're going to wrap it up for this episode, ladies and gentlemen. It's Marilyn Bartlett. She is a senior fellow over at NASHP. I'll put the call notes and the links to the hospital cost tool in the comment section, but that's going to wrap it up this week. Join us next time. We're going to have another guest, and we're going to be talking about a topic to give you and your employees a snowball's chance in healthcare. God bless, and have a great weekend.